name is Ahmed Abdelaatti. I'm a senior registrar in the Mater Misericordiae University Hospital in Dublin. Today I'm going to present a lecture about anesthesia for elective abdominal aortic aneurysm repair, and to declare I have no conflict of interest to present that. Today I'll be speaking about the elective AAA repair, and in the next lecture we will be speaking about the EVAR and the rupture AAA. So to start with definition, incidence and mortality. So aneurysm is a Greek word which means dilatation or widening. An aortic aneurysm is a permanent dilatation more than 30 mm in a way along the aorta. The incidence is 10% in males and aged 65 years old, and 3% in females aged 65 years old. Mortality for open elective repairs is 1 to 6%, and for rupture the AAA it's 1 in 200 deaths. Surgical mortality ranges between 32 to 70% or 50% in different sources. 42% die before hospital within 1 year. It's closely linked to the degree of hypotension, massive blood transfusion, and cardiac arrest, and that will be the part will be talking about resuscitation of the ruptured AAA. The etiology, there is positive family history, and it's more in males more than females. However, when it happens in the females, there's higher risk of rupture and higher mortality. Is more common in Caucasians than in Black and Asians. Atherosclerosis is the most common cause. Smoking is the most important modifiable risk factor in the formation, progression, and rupture risk. Other causes like Marfan's syndrome, TB, Salmonella, and Takayasu's disease. The pathophysiology, it's an inflammatory process that leads to breakdown of the elastic elements and of the blood vessels, leading to increase in the protease activity and the formation of mayoral thrombus in the arterial wall, and as a result of that, plasminogen activation, which leads to expansion and eventually rupture. The strongest predictor of ruptures are the annual expansion rate and the maximum diameter. The pathophysiology is very important. So the annual risk of rupture of large AAA is 18% in women and 12% in males. The reduced expansion rates are seen in diabetic patients. The risk of aneurysm rupture increases in a nonlinear fashion, as you can see on the right side of the screen here. So when the aneurysm diameter reaches up to 5 cm, then the risk starts to increase in this fashion. Management strategies are divided into two main categories: the non-surgical management and surgical management. The non-surgical management will be focused on the modifiable risk factors and control of coexisting disease, like smoking cessation, as it slows down the aneurysmic growth by 15 to 20%. It improves the wound healing as well in the post-operative period, and it decreases the cardiorespiratory complication that result from this kind of a procedure and aortic cross-clamping, and we'll be talking about this in the pathophysiology. Statins, the aim is to minimize perioperative myocardial ischemia, and it may decrease the aneurysm growth. Low-dose aspirin decreases the major coronary events. Beta blockers and ACE inhibitors for patients with high-risk cardiovascular disease. And the other aim also of presenting these medications is that you will see those patients and those medications to be familiarized with. Then the surveillance programs, they use the abdominal ultrasound, as it has detection specificity and sensitivity of 100% to monitor the aneurysm size and to identify patients with high risk of rupture. It monitors the rate of AAA expansion, aneurysms between 4 to 5.5 cm in diameter as per the small aneurysm trial and the aneurysm detection and management study ADAM-US. They have less than 1% annual rupture rate, and as a result of that, there is no need for surgery, or surgery at this stage will not add any improvement in mortality. Then surgical management. The aim of the surgery is to replace the aneurysmal segment of the aorta with a synthetic graft. Two main surgical techniques are available: the open repair, which may be the only feasible solution for some patients, and EVAR, or endovascular aortic repair, which is more popular and it's becoming more frequently done nowadays. The choice of the surgical technique depends on the aneurysm morphology, the site, shape, angulation, involvement of renal arteries, and the size of the iliac vessels. I'm involving that for you to understand how the surgeons decide and how complex the aneurysm may be, and that will make a different decision for the kind of surgery. The other factors are the comorbidities that the patient have and the age. So the next question is EVAR versus open repair. This is usually a matter of conflict and debate between the surgeons and between the intervention radiologists. So in Ireland here, it's always the EVAR is always done by the vascular surgeons. In the UK, EVAR is usually done by the intervention radiologists, and differs in many countries of the world. So it's always a matter of debate, EVAR versus open, and you will be seeing that in the practice. So the EVAR 1 trial here was published in the Lancet in 2016. They followed 17,000 patients for 13 years. The conclusion of that trial was at 0 to 6 months, patients in the EVAR group had a lower mortality than in the open AAA repair. But beyond 8 years of follow-up, the open repair had a significantly lower mortality. So you want to say that the overall benefit is for the AAA repair, and this study was done in the UK. So also the increased aneurysm related mortality in the EVAR group after 8 years was mainly attributable to secondary aneurysm sac rupture. Those complications of the EVAR stent you will see along the course, they usually have a lot of complications. They have a lot of endoleaks. You will have EVAR stent inserted, and then you will have the complication of the EVAR stent again, and they will need an emergency repair. So put that in mind as well. They found also the increased cancer mortality was more on the EVAR group. But another study was published in the JAMA in July last year, and also was published in Nature, to compare EVAR versus open repair as well, and the conclusion of that, they studied 17,000 patients over 13 years. Conclusion was saying endovascular aortic repair was not associated with a difference in long-term survival during more than 13 years maximum follow-up. The reason for these findings will require studies to consider specific graft mix models, adherence to the instructions of use, and types and reasons for re-intervention. So they wanted to say that there is no difference between the EVAR versus the open repair, but you have to be committed to the manufacturer rules for insertion of the stents. Then the surgical approach may be transperitoneal approach, longitudinal or transverse abdominal incision. Retroperitoneal approach, which is decided by the surgeons based on the number of surgeries or if this patient has complex surgeries in the past. Laparoscopic assisted AAA, which is not common, and after the surgical procedure, what they do, they open the anterior wall of the aorta and they insert the synthetic with end-to-end anastomosis, as you can see on the left side of the picture. There is another, and usually the grafts are in two types, either this tube graft or this trouser graft or bifurcated graft. And this is important for you as well. When they do the bifurcated graft, they usually release one limb by one limb, and this makes the release of the clamp less aggressive as just releasing the whole aorta suddenly. Pre-operative assessment, management, and investigation. So AAA surgery is a high-risk surgery in a high-risk population. AAA patients are commonly arteriopathies, and they have a lot of comorbidities like coronary artery disease, hypertension, cerebrovascular disease, smokers, peripheral vascular disease, COPD, diabetes mellitus, and chronic kidney disease. Elective surgery have much lower mortality and morbidity than emergency surgery for AAA repair. So it's 7% for the elective repair versus 36% for the emergency repair, or up to 50%. The aim of the preoperative assessment is to stratify and minimize perioperative mortality and morbidity risk. All patients should commence statins and antiplatelet medications. The arterial blood pressure should be well controlled. Lifestyle advice should be offered, like smoking cessation. Patients should continue taking beta blockers if already taking. Diuretics and ACE inhibitors should be considered on a case-by-case basis. Preoperative assessment, again, you will find those patients on a lot of medications like clopidogrel, prasugrel, and ticagrelor. Cessation in the perioperative period is usually complex for those medications, and this depends on the indication, and you always should seek for cardiology input. Acute cessation in the presence of a drug-eluting stent is catastrophic, so put that in mind. Recent data suggests that continuation of clopidogrel may not increase the risk of bleeding, so it has to be weighed, the risk against the benefit, and you always keep in contact and get an input from the cardiology. Also, the functional residual capacity of those patients should be more than 4 metabolic equivalents, which equal to anaerobic threshold of less than 11 ml per kilogram per minute if you are doing the cardiopulmonary exercise test to predict the perioperative mortality. Then, risk stratification. There's a lot of scores that you can use for this task. So Goldman and Detsky for major adverse cardiac events, Hartman index ruptured aortic aneurysm. They have 5 items. Everyone has 1 point score. So age more than 76 years, 1 point. Creatinine more than 190 microgram per liter is 1 point. Hemoglobin less than 9 gram per deciliter is 1 point. Loss of consciousness is 1 point. Ischemic ECG is 1 point. So if you have a score more than 2, this equals to a mortality of 80%. Then you have the Glasgow aneurysm score for both elective and ruptured AAA. A score of more than 84 equals to 65% mortality. They have also 5 items. Age of the patient in years. Shock is given 17 points. Myocardial disease is given 7 points. Cerebrovascular disease by all grades starting from a TIA up to stroke is given 10 points. Renal disease, if the urea is more than 20 micromole per liter and or creatinine more than 150 micromole per liter, are given 14. But put in mind that all these scores are not absolute scores. They have a lot of limitations. It's just a way to help you to supplement a clinical decision. Then pre-operative investigations are normal as you do in every hospital, like full blood count, urea, electrolytes, coagulation screen, chest x-ray, and ECG. Then, as per your hospital protocol, in my hospital we do echocardiogram and PFTs for every patient doing this operation. Other cardiac investigations include cardiac catheter and dobutamine stress test. The aim for cardiology referrals are to optimize those patients and to decide if they need coronary revascularization before AAA. So put that in mind. What's your aim from the cardiology referral? It's not just a referral. You are referring to get an opinion. So patients with COPD as well will benefit from regular nebulizers and chest physiotherapy. Pathophysiology of Aortic Cross-Clamping. This is really a very important topic. If you understand it, you will understand all the intraoperative management so easily. So that's very important again. Aortic cross-clamping causes profound physiological and pathological changes. It causes also release of anaerobic metabolites into the circulation, and it causes end organ ischemia. On clamp release, you have release of anaerobic metabolites into the circulation, a second sequence of physiological and pathological disturbances. Then this effect will depend on the site of the clamp, the length of cross-clamping, the patient's physiological reserve, and whether it is elective or emergency. Pathophysiology of aortic cross-clamping, cardiac effects. So cardiac effects depend on where the clamp is. So if the clamp is suprarenal clamp, go back to the physiology again. So cardiac output equals heart rate multiplied by stroke volume, and it also equals blood pressure divided by systemic vascular resistance. From that, if the systemic vascular resistance have increased, this will lead to increase in the workload, eventually will increase the blood pressure or causing heart failure. So this depends on the cardiac reserve. So the response will be either hypertension or heart failure. And it's usually minimized when the clamp is more distally. They will also have regional motion abnormality, and this will be in 33% of patients. The infrarenal clamps have minimal to modest changes, and then the supraceliac clamps will result into drastic cardiac changes. So it will increase the MAP by 50%, it will increase the filling pressures by 40%, and decrease the ejection fraction by 40%. It will also cause regional wall motion abnormality in more than 90% of patients, even if they have normal background cardiac history and cardiac functions. And then look at after that to the cardiac compensation. So on cross-clamping, this will increase the preload, which will increase the contractility at the end. By Frank Starling law, increasing the preload increases stretch, eventually leads to increase in the contractility. And sympathetic tone will increase the heart rate and blood pressure, and this will eventually increase the contractility as well. What are the therapeutic aims of these cardiac effects? So you understand what happened, and you understand your therapeutic aims. So your aim is to reduce the afterload and reduce systemic vascular resistance, and this can be achievable via vasodilator drugs. You can do this also by anesthetic agents if you deepen the level of anesthesia, or regional anesthesia if you have an epidural inserted in. You can use J2N or sodium nitroprusside as vasodilator drugs. Increase contractility using intraoperative is your second aim, and this can be achievable via adrenaline or dobutamine. So you need to have a central line. But put in mind that increasing the contractility will be on the expense of the oxygen, the balance between the oxygen supply and demand. So your aim here is to decrease the oxygen consumption and increase the supply. And this can be achieved within the autoregulation limits through vasodilator drugs that increase the coronary blood flow and aims to make redistribution of blood from the epicardium to the subendocardium and increase the inotropic effects. And at the end, this will decrease the left ventricular in systolic volume. So what is the role of the venous system as well? So on cross-clamping, this will lead to this decrease in the distal arterial blood supply, which will decrease the venous return and emptying the venous system. This will eventually lead to decrease in the compliance of the vessels because it's empty. And according to Laplace law here, if you look at this vein here, that's just a shape for the vein, and the diameter will be decreasing when the vein collapses. The wall tension will be increasing, and this will increase the pressure according to Laplace law here. So P equals 2T over R. So the radius will decrease and the tension will increase. The net result of that is an increase in the central venous pressure. And if you're doing transesophageal echo or having a Swan-Ganz catheter, you'll find an increase in the pulmonary capillary wedge pressure as well. During infrarenal clamp, the redistributed blood pools in the compliant splanchnic circulation, and that's one of the other effects. So the blood is redistributed and back into the splanchnic circulation. This causes as well swelling of the viscera, and this will cause abdominal hypertension and increase in the possibility for compartment syndrome. So this is one point for you to focus on the post-operative care. So if you understand the pathophysiology, you'll be able to do the intraoperative management and the post-operative management. So the net effect depends on the sympathetic tone, the anesthetic technique you are using, and vasopressor agents. The anesthetic technique will differ if you're using only general anesthesia or if you are using epidural as well. So epidural will cause vasodilatation, and this will increase the redistribution of the blood in the splanchnic circulation. In the renal effects due to the cross-clamping, the kidney requires constant perfusion pressure, which is regulated by the afferent arterioles of the kidney and the humoral factors. Renal vessels can be affected by aortic cross-clamping. Either it is suprarenal or infrarenal, so both will affect the kidney. For the suprarenal clamps, this decrease the renal blood flow up to 95% will cause acute tubular necrosis, plus minus the possibility for CRRT in the post-operative period. The risk factors for this include the length of cross-clamping, the pre-existing, if there is a pre-existing chronic kidney disease, age of the patient, and if there is diabetes mellitus previously. For the infrarenal clamps, this will decrease the cortical blood supply, and this eventually results in decrease in the GFR and decrease in the urine output. Decreased GFR in 67% of patients happens. Decrease in the renal plasma flow happens in 48% of patients. This reduction is maintained for 6 months post-operatively, whatever if the urine output is good intraoperatively or not. A reflection of what happens. Then the spinal cord ischemia, also the spinal cord perfusion depends on the mean arterial pressure and the spinal artery minus the CSF or venous pressure, whatever or which is higher. On cross-clamping, the anterior this decreases the anterior spinal artery pressure, leading to venous engorgement, which decreases the effective perfusion pressure, and this increases the risk of ischemia as well. So to understand this as well, you have to look at the anatomy of the spinal cord and how it is supplied by blood. So it depends on collaterals for perfusion, and the main collateral branch here is the artery of Adamquick's, and this artery, you all know that it has variable origin. So it may arise from the level of T9, T12 in 75%, or L1, L2 in 10%. So that's distal origin, or it may arise from a proximal origin to 5 to T8 in 15%. So the distal part of the spinal cord perfusion will depend on the origin of the artery of Adamquick's. Also, the pathogenesis of neurological impairments and paraplegia is important to understand. Hypoxia and reperfusion injury and the free radical production locally are the main risk factors for developing the paraplegia and neurological damages. What are the risk factors for neurological damage? The level of cross-clamping, duration of the clamp, age, urgency of the operation, episodes of hypotension. So it's very important to keep the patient normotensive or slightly on the higher side to maintain the adequate perfusion pressure of the vital organs, and to avoid the peaks and the troughs in the blood pressure. So it's always a smooth control of the blood pressure. Put that in mind. The aortic dissection, if it happens as well, and this may happen on applying the aortic cross clamp if the blood pressure is high, or it may be part of the complication of the aneurysm. Incidence is 40% of developing those neurological injuries, and the recovery is 50% of those. The infrarenal is usually less in complication than the suprarenal clamp. The techniques used to prevent the neurological damage are surgical techniques, maintaining adequate blood pressure, as I said earlier, CSF drainage in some patients. So if the level of the cross clamp is higher and the aneurysm is complex, so this usually the surgeon will ask for CSF drainage. There is no great evidence for that, but still there is some evidence for it. And I have seen one patient who had weakness post-operatively, and we timed the spinal drainage to the heparin that was given intraoperative, and we did spinal drainage, and the patient improved. The cooling techniques as well, but there is no much evidence for that, and the aim is to keep normothermia. So ischemic preconditioning is another thing. Free radical scavengers, we'll talk about them. There's no evidence for any of them, but we will talk about. Then the lung complications, release of inflammatory mediators following the cross-clamp release leads to increase in the pulmonary vascular resistance, pulmonary hypertension, pulmonary vascular permeability is increased as well, which leads to pulmonary edema and acute lung injury. The increased pulmonary capillary leak is the result of the release of the humoral factors like thromboxane, which stimulates the neutrophils and causes platelet activation. This leads to the release of oxygen-free radicals and the release of elastase, which will eventually lead to increased vascular permeability. Activation of the renin-angiotensin system as well, and the complement will lead to smooth muscle contraction. Then the visceral effects. The mesenteric vessels are affected by the cross-clamp, leading to vessel ligation, reduced or altered blood flow, and temporary occlusion. The bowel can be affected whether the clamp is supra or infrarenal. The most common site of clinical ischemia is the descending colon supplied by the inferior mesenteric artery. The mortality is 50% as a result of the bowel ischemia. The altered blood flow to the gut can be caused by patient factors or operative factors. The patient factors are usually hypovolemia, so it's very important to keep normovolemia. So normovolemia, normotension, normothermia, both all this in mind. The arrhythmias and the decreased cardiac output as well, and operative factors are related to emboli or thrombosis. In the systemic effects, the cross-clamp will result in the anaerobic metabolism, ischemia, and even necrosis. This results in the buildup of anaerobic metabolites such as hydrogen ion, ADP, potassium, adenosine, hypoxanthine, xanthine oxidase, and purines. Upon clamp release, this will lead to these anaerobic metabolites will enter into the systemic circulation, causing vasodilatation and cardiac dysfunction. The combination of hypotension and cardiac dysfunction will lead to cardiac arrest. So once a cross-clamp happens, you always work for the point you will reach to the declamp and release of the clamp. So you have to work on improving the fluid status of the patient. Your patient has to be normovolemic. Your blood pressure should be on the higher side or as the baseline of the patient to keep it within the baseline before induction, to keep it within the autoregulation limits, and avoid peaks and troughs in the blood pressure, avoid tachycardia, avoid hypertension, avoid hypotension. All these are very important, and if you usually done them very well, your declamping will be smooth and you will not have drastic changes in the blood pressure or severe metabolic acidosis as usually happen. The level of the clamp will determine the risk factors for reperfusion syndrome. So duration of the clamp, hypovolemia, comorbidities, emergency surgery, and age of the patient, all these are determinants for the risk factors of syndrome. And again, to start intraoperative management, you have to prepare before you start. The most important thing you need to prepare is your emergency medicines, as you can see from the right side of the patient. And if I have the time, I will mention them by one by the concentration. These are really very important. If you have them, you are safe. So do blood cross matching, emergency drugs, as I said, induction drugs, vasopressors, and inotropes for the infusion intraoperative, setup of invasive and non-invasive monitoring, rapid infusion device, and the fluid warmers, warming blanket, infusion pumps, and for the inotropes and cell saver if you have. The conduct of anesthesia, you start by monitoring. You will need here 5-lead ECG for detection of myocardial ischemia. You need invasive arterial blood pressure and usually put it awake because those patients are arteriopathies. Once you put them to sleep, it's hard to put the arterial line in. CVC insertion, central line insertion, usually after induction of general anesthesia. Urinary catheter insertion, temporary probe insertion, plus minus cardiac output monitor, and BIS, the bispectral index or inotropy. If you have it, there's not much evidence to support, but it's a good indicator of the depth of the anesthesia. Also insert 2 large bore IV cannulae before induction of anesthesia. And come to the anesthesia and analgesia. So anesthetic management focuses on acute hemodynamic changes with aortic cross-clamping and unclamping, as I explained in the pathophysiology, maintaining organ perfusion and oxygenation, attenuation of ischemia reperfusion injury, intra and post-operative analgesia. Thoracic epidural catheter is usually placed at the level of T8-9 at the level of the upper part of the incision before induction of anesthesia. And then induction of anesthesia, you have to do adequate pre-oxygenation, use high-dose opioids to depress the vasopressor response and to minimize the tachycardia and hypertension, small dose propofol or midazolam just to avoid any sudden drop in the blood pressure, avoid massive swings in the blood pressure, and then muscle relaxants, antibiotics before skin incision. And then for the maintenance of anesthesia, you need mixture of inhalational oxygen, air, gases for the maintenance. Analgesia can be maintained by either the epidural, but use a small dose of the epidural to avoid the drop, or small concentrations to avoid the drop in the blood pressure. You need to have, or the other option will be the balanced opioid technique, either remifentanil infusion or morphine infusion. It depends on the availability and your hospital protocol. The surgeon will ask you to give heparin, and this usually 75 to 150 international units per kg IV before the cross-clamping, and the target ACT will be 2 to 3 times the baseline. The aim for that is to avoid any release of atheroscleromatous plaques into the circulation with the application of the cross-clamping. Then cell saver, if you have it, should be used to increase the autologous blood transfusion. Maintenance of anesthesia also, so you have to do serial EVG to check the respiratory and metabolic status of the patient. You need facilities for rapid infusion of warm fluids like level 1 fast infuser device. If you don't have it, you can insert a Vascas. You use it for 2 reasons: intraoperatively, just as a quick IV infusion access, and for post-operative, those patients may need the CRRT. Maintain normothermia, avoid lower body temperature during cross-clamping, so don't put the bear hugger on the lower half of the body, so this will be exposed to ischemia from the cross-clamping, and warming will maximize the neurological complication that may happen. So usually put the bear hugger on the chest and neck of the patient. Maintain the blood pressure with vasopressors if needed. GTN if hypertension occurs in response to cross-clamping, and the other thing you may use is to deepen the level of anesthesia. Target mean arterial pressure within the autoregulation limits. So if your patient is non-hypertensive, so check his baseline blood pressure measurement before you put him to sleep and keep it in the same level. In preparation for unclamping, so once they start the clamping, you start your preparation for the unclamping. You need to also always communicate with the surgeon. You have to understand at which stage he is. He has to tell you before applying the cross clamp, because you need to decrease the blood pressure to avoid any complications on the aorta like dissection. And also before declamping, he has to tell you by enough time usually 30 minutes before release of the clamp. So you start on improving your fluid status by fluid loading, and you start weaning your vasodilator drugs and start titrating your vasoconstrictor drugs. All this is aiming for the sudden release of the metabolites into the circulation and sudden reperfusion of the two legs and pelvis, which will take big amount of blood pressure, so your patient will have drastic and sudden hypotension. So again, wean off vasodilator drugs if used, start vasoconstrictor drugs, usually noradrenaline in a small dose, and titrate up as needed. Repeat the EVG 10 minutes before declamping, so any change after that will be as a result of the declamping. Use metterminol boluses, phenylephrine boluses, ephedrine boluses. They have to be in your hand. Keep adrenaline infusion ready. Repeat EVG 10 minutes after declamping or after you stabilize your patient. Use sodium bicarb if acidotic with pH of less than 7.2. And from my experience, if you work it well enough before the declamping, you will not need the sodium bicarb. Then fluids, blood and blood products. Fluid loading during cross-clamping using crystalloids, and cautiously give colloids because they increase the bleeding tendency. In addition to their other side effects. Maintain your hemoglobin between 9 and 10 because they are mostly cardiac patients. Maintain CVB between 12 and 15. CVB nowadays haven't have a valuable measurement as it is the value for it is decreasing. Usually CVB is now replaced by the filling pressure or by the PPV, which is pulse pressure variation or stroke volume variation. If you have them in your device and you know the values and you know the limitations and you know when to use them and when not to use them, aim for less than 13%. This means your patient's adequately resuscitated. Blood products, fresh frozen plasma, platelets, cryoprecipitate, after hemostasis usually and removal of the cross clamp. You can use a thromboelastography if you have it in your institute. If you don't have it, continue resuscitation as per your protocol and consult hematology if needed. The organ protection, so maintain vital organ perfusion, oxygen delivery and euvolemia. Myocardial damage can be avoided by maintenance of oxygen supply. Adequate saturation is needed. Minimize demand by avoiding the increase in the heart rate and the drop in the blood pressure. Use vasodilator drugs to decrease the left ventricular end-diastolic volume, which will decrease the ventricular wall tension, and this will decrease the force of contraction and improve the endocardial perfusion at the end. So for kidney protection, the main cause for renal complication is decreased renal blood flow, decreased renal perfusion pressure outside the autoregulation limits, increased the renal vascular resistance by 30% associated with aortic cross-clamping, the release of myoglobin into the circulation from ischemic tissues, which will lead to a decrease in the local nitric oxide release, leading to acute tubular necrosis. Also, the ischemia reperfusion injury is a second factor. Decreased renal cortical blood flow, prostaglandins imbalance, increased activity of the renin-angiotensin system. Intraoperative urine output doesn't correlate with the degree of decreased GFR, as I mentioned before. The rates of CRRT are similar with suprarenal and infrarenal cross clamps. There is several drugs that were used in the past, like dopamine, N-acetylcysteine, mannitol, and furosemide. All of them have no benefit. So the post-operative complications are divided into respiratory complications, and this represents 8 to 12%. Pneumonia, 5% of patients, atelectasis, respiratory failure, thromboembolic manifestations, cardiovascular complications are 15%, between ischemia, infarction, and 2 to 8% arrhythmias. Cerebrovascular complications represent 22% in the form of cerebrovascular disease, 1 to 2%, carotid insufficiency, cognitive impairment, confusion, and delirium. And then renal complications, 5 to 12% in the form of AKI or ATN or CKD, or renal vascular injury, or the requirement for hemodialysis. This happens in 1 to 6%, or the ureteric injury, this happens in less than 1%. Neurological injury, spinal cord ischemia and paraplegia are common side effects of the cross-clamp. GIT bowel ischemia and acute compartment syndrome. So you have to look after these complications in the post-operative period. Surgical complications like bleeding, DVT, pulmonary embolism, wound or graft infection. The post-operative management will be in the ICU mainly, or in the HDU if you have a well-established system. The epidural analgesia for post-operative pain control, early mobilization and physiotherapy after surgery, DVT prophylaxis, adequate hydration, elastic stockings, and heparin, close monitoring of the complications. Thank you.
Thank you very, very much, Dr. Ahmed. Here we have some questions for you, if you don't mind. So the first question is, any evidence of mannitol usage for oliguria in this case?
No evidence.
No.
I have said it.
Okay.
But the surgeons, it's always a battle between the surgeons. I worked with one of the surgeons here in Ireland. He's always asking for this, but there is no evidence to support that.
The next question is there any rule for CP machine in decreasing the risk of SC and renal ischemia?
What's CP machine?
The CP machine rule in decreasing the risk of SC and renal ischemia.
What's CP machine?
What is the CP machine?
Yeah, I don't know the abbreviation. What's the CP machine? What CP stands for?
We are asking. So we forward this question to the question asker, and we now move to the next question. So there's a question on our YouTube channel. Is there any anesthetic consideration intraoperative to prevent or decrease the incidence of rupture of the aortic aneurysm?
So those depend on your management and communication between you and the surgeon. As I have mentioned, you always communicate with them. So at the time your is a cardiopulmonary machine. CB machine is a cardiopulmonary machine, sir. As answered by Dr. Ahmed Ibrahim, one of our it is the answer of one of our attendee, Dr. Ahmed Ibrahim. The abbreviation of CB machine is cardiopulmonary machine. I'm not aware about the cardiopulmonary machine that we use intraoperative. What's a cardiopulmonary machine? If you know better. So not for this kind of surgery. We are talking here about infrarenal aortic aneurysm, not for this kind of surgery. Thank you, Professor Ahmed. Thank you. So back again to Dr. Hisham, what was the question again?
The question is the anesthetic considerations to reduce the risk of rupture of the aortic aneurysm intraoperative.
So number one, you have to have your cardiac blood pressures in the autoregulation limits. So in other words, if your patient look always to your patient background or baseline blood pressure before the start of surgery, and always achieve this. Number two, at the time of the application of the aortic cross-clamp, the surgeon has to tell you that he's going to apply it, and you have to lower the blood pressure a little bit. You usually keep the blood pressure on the higher side to provide adequate perfusion of the vital organs. So at this critical point, you have to use the blood pressure to avoid the rupture of the aorta. So that's one of the things. And so the key role and the key concept in this is communication between the anesthetist and the surgeon.
Thank you very, very much, Dr. Ahmed. This was all the questions for today. I would like to thank all the attendees, and of course before this all the lecturers for the 9th session of the MEGA online course. We We have one more question. Is there cerebral protection during clamping and declamping, Dr. Ahmed?
So the idea is to maintain again the auto-regulation within the limits, to maintain the blood pressure to the same level, the baseline of the patient. There was in the past the use of some saline and those kind of things. It's not doesn't have any evidence of support, and is not also the aortic surgery. It was planned for the carotid endarterectomy, but there is no evidence of support for this. It's all depending on maintaining adequate perfusion pressure and adequate normothermy, even more hypothermy.
We have also one question from Dr. Ahmed Rabia. After declamping, do we use vasoconstrictive drugs or vasodilator drugs?
So again, back to the pathophysiology, which I focus too much on it because this will give you the answer. What happens during the clamping is accumulation of anaerobic metabolites, which will and the sudden reperfusion as well of the lower limbs, and the release of a lot of substance that will cause vasodilatation and increased permeability. So what will happen is vasodilatation on top of your blood pressure. So you are going to use vasoconstrictor to maintain your blood pressure and fluids support.
So there's another question about the role of catheter replacement draft through the femoral artery.
Catheter
replacement draft.
Draft or graft?
Draft.
To femoral artery. This is a cervical point, and it depends on the size of the femoral artery. It's usually decided by the surgeon. So they usually decide between open or EVAR, and even when they are doing EVAR, so two groin incisions passing through the femoral arteries, this depends on the size of the femoral artery. So you may bypass that and do an iliac approach. Also after the declamping, if there is ischemia of that's the other part of the question, if there is ischemia in the lower half of the body, they may do femoral crossover. So once they release a clamp and finish the anastomosis and there is no leak or there is no bleeding, they check the lower limbs, they check for ischemia, and that's the point that they will decide if the patient needs any crossover or not.
So we have another question here, a lot of questions for you, Dr. Ahmed, about the anticoagulant regimen.
Okay. Intraoperative or post-operative? Perioperatively. So perioperatively, the patient usually are put on low-dose aspirin and statins, unless they don't have a cardiac issue. If they have another cardiac problem, they will be put on more. They will be on aspirin, clopidogrel, or prasugrel, as I mentioned, and those are usually cardiac issues and will be established by the cardiology. Secondly, intraoperative, all what you need is heparin, and this is targeting to increase your ACT by 2 to 3 baseline, 2 to 3 times the baseline. Post-operatively, usually it's low molecular weight heparin, or depending on your hospital protocol.
Thank you very much, Dr. Ahmed. We would like to thank you again for the very interesting lecture, and thanking also Dr. Ashraf Tayyar. We thank all the attendees for attending today, and wait us for the next session in the Mega online course, and of course for the second stage of the course there will be more professors and more lectures, inshallah.
Thank you very much.
Thank you.
Thank you.